Okay, so this is sort of the breakdown of how we're going to do it. The first hour, we're going to cover congenital malformations, neuromuscular disease, and usually we'll get into infectious complications before break. And then after that, we'll get into sort of the bread and butter of what I do: asthma, cystic fibrosis, BPD, etc. All right, so I like to start with a question just to get everybody's mind working right after lunch. Full-term neonate develops cyanosis and increased work of breathing shortly after birth. That cyanosis is relieved with crying. These episodes appear cyclic. They occur during rest and feedings. They resolve when the infant starts crying. Your differential diagnoses would include, and they're listed here for you. So this is sort of the stereotypical breakdown that we get every year, which is why I like this question and I keep it in here. So the correct answer is actually E. And we're going to talk about both of those first. Okay, so choanal atresia. Most of these malformations are not common, but I think that you'll probably encounter at least one of all of these as you continue to practice in pediatrics. So choanal atresia, seen in about 1 in 7,000 live births. If it is bilateral, then just like the vignette, you're going to see that presentation with upper airway obstruction. The child becomes cyanotic when they're at rest, when they're feeding, because they are obligate nose breathers. When they're crying and they open their mouth, of course, that relieves the obstruction. If it's unilateral, then it's a completely different scenario. So you're going to see an older child presenting later on in life with unilateral nasal discharge or unilateral nasal obstruction. For choanal atresia, to make that diagnosis, you would, of course, attempt to pass a catheter through the nose. If you're unable, then you can obtain a CT with intranasal contrast. That will show you that atresia. And then just for the boards, keep in mind that if they give you a vignette, which sounds a whole lot like choanal atresia, just like I did, they may not be so straightforward and say, is this choanal atresia, but rather what syndrome would this be associated with, such as Charge or Treacher-Collins. So as far as management, of course, we're going to place an oral airway. They've got to be able to breathe. We've got to be able to feed them at the same time. So gavage feedings, and then consultation with your surgeon, your ENT, to get transnasal puncture, stenting. They put those little trumpets in, or resection of that posterior nasal septum. Now, the other part of that first vignette was the piriform aperture stenosis. Relatively uncommon, but can occur. It's a bony overgrowth at the anterior bony opening, or the piriform aperture. So the infants present exactly like a child with choanal atresia. They've got noisy breathing. They can develop distress. This also can be seen with other anomalies, pituitary abnormalities. And on CT, instead of finding what you would expect with choanal atresia, instead you're going to see that small nasal opening at that bony opening. And then usually for these children, nasal stenting is sufficient. Really severe cases, such as your premature infants, may require tracheostomy until they're big enough to undergo surgical correction. Okay, so just while we're on the subject of the nose, some non-congenital problems real quick. Just like with unilateral nasal choanal atresia, foreign body would be the other thing in that differential where you've got unilateral nasal discharge. With foreign body, it's often going to be foul smelling. Your boards love to give vignettes of toddler age, 2, 3-year-old, foul smelling unilateral discharge. Think about foreign body, because if there's a hole, you know toddlers are going to stick something in it. Epistaxis. Boards like this one too. If the vignette is an adolescent, you need to think about drug abuse. For most other children, nose picking, obviously most common cause. But then we're also going to see an increased incidence during the winter months when everything's dry, or this year in the South when everything's dry. But also foreign body can cause nosebleeds, tumors, and of course trauma. And then if your vignette is giving you nasal polyps, it is saying CF unless otherwise spoken. So if that's in there, think CF first. Other things can cause it. Chronic sinusitis can cause it. Allergic rhinitis can cause it. That aspirin triad you've heard about with asthma, allergic rhinitis, aspirin sensitivity. And then as far as nasal polyps, our therapy, first line will be nasal steroids to attempt to shrink or reduce the size of that polyp. In the cystic fibrosis population, it's often surgical removal of those polyps. Okay, so we're just going to move down the airways is the way I've sort of structured this. So we're moving down into the oral area. So lingual ankyloglossia or tongue-tied, this is a restriction of the tongue movement caused by a prominent lingual frenulum. More common in males, as is most of the congenital anomalies in the respiratory system. So that's kind of a little hint for you. Most of these infants do just fine. Of course, surgical correction would be a frenulectomy. This is an outpatient procedure. Lingual thyroid, that's a failure of the thyroid to descend to its rightful place. And so it remains at the base of the tongue. The important part of this is that it can cause airway obstruction. So surgical removal would be indicated under those circumstances. Thyroid hormone can be used if they're not obstructing to reduce the size of that remnant. And then moving straight on down into the neck, thyroglosal duct cyst. It's a cystic mass in the neck. Most of these are asymptomatic, but they can become infected. They can rapidly increase in size and, of course, would cause airway compromise under those circumstances. Okay, so let's move on down. Next question. 4-month-old is brought into your office. Mom saying, she just breathes funny. She makes all this noise. And she noted it right after the child was born. She hears it when the baby breathes in. She's a very astute mom. Most don't tell you that. So you're thinking the kid has laryngomalacia. So this is one of those no-no questions. The following statements are true except. So what we're looking for is a statement that is not true. It is the most common congenital anomaly of the larynx, most frequent cause of stridor in infants. Laryngomalacia is made worse by exertion, crying, feeding, agitation, or supine positioning. The stridor typically develops within the first few weeks of life, decreases in severity over the next several months, and resolves by 6 months of age. The diagnosis of laryngomalacia is made by flexible laryngoscopy while the child is awake so that you can see things under dynamic conditions. Well, that's surprising. Okay. So the false statement of these is C. And we're going to go over next laryngomalacia. But let me just precede that discussion with this. All laryngeal lesions typically will produce inspiratory problems. And I say that's pretty uncommon for a mom to come in because they usually don't come in and say the child has trouble when she breathes in. It can be biphasic. That's a severe obstruction, but typically will be inspiratory. Laryngeal lesions can cause hoarseness. Of course, they can cause aphonia or difficulty vocalizing. There can be feeding disorders. If what you hear is an expiratory sound, not biphasic, you're not hearing it all the way through, but an expiratory sound, that is a lesion that's occurring below the thoracic outlet. So that's a clue for you. Okay, so where do we miss this? Laryngomalacia, it is indeed the most common congenital anomaly of the larynx. It is one of the most common causes of stridor that you're going to see in your practice in infants. For the most part, this is a self-limiting problem. It's going to resolve spontaneously as the child ages. Rarely are we going to see something that's going to require surgery. Indications for that would be that the child simply can't feed and can't grow. They're expending too much energy trying to overcome that obstruction. So, true enough, the stridor does typically develop within the first few weeks of life. here's one part where we missed it. It progresses in severity over the next several months, and you need to be sure that you inform the mom of that. It's going to get worse before it gets better, so that mom doesn't think you don't know what you're doing and go somewhere else. So really bad cases, we see sternal retraction. I've even seen a pectus excavatum develop because the child was pulling in so hard. They can have respiratory distress, and just like the vignette that was given, it is made worse with exertion, with crying. If you lay them on their back, they're worse. If you flip them on their belly, they're better. With the current rulings of back to sleep, very few parents can tell you if I lay them on their tummy, it gets better, or are willing to tell you that, because we don't usually put the babies on their tummy. But you can certainly do that in the office, and that's a very quick test. So laying them on their stomach or laying them on their side and extending that neck should make that sound less. And it usually resolves somewhere between 18 and 24 months, not 6 months, like was given in the question. But the diagnosis has to be made under dynamic conditions, because if you are ventilating that child, you're going to distend the airway. You're never going to see that characteristic flop over of the upper airway as they're breathing. For really bad cases, tracheostomy can be placed. There's a whole lot of new little surgical procedures that can be done, epiglotoplasty, supraglotoplasty, where they sort of resect back that floppy tissue, and that can prevent tracheostomy. So this is an example, and you can see as the baby breathes in, everything flops down. As the baby breathes out, it all opens up for you. Here. Another anomaly that we commonly see is subglottic stenosis. This can be congenital. It can be acquired. And you can make that differentiation simply by the story that you're given. If you've got a history of trauma, you've got a history of prolonged intubation, then of course that's acquired. It's a narrowing of the cricoid lumen just beneath the vocal cords. If it's congenital, then it's going to improve as the child gets older. If it's acquired, it probably is what it is. But diagnosis is made by direct visualization. And we treat only those who are symptomatic, because oftentimes treatment makes it worse. We can open it up, but then it scars down worse than what you had. And you can see here exactly that narrowing that we're talking about. If they are acquired and, of course, old enough to perform spirometry, what we're going to see is what's called a fixed obstruction, and that's a blunting, a squaring off of the inspiratory loop. We also see expiratory loop. We also see a blunting or squaring off of the inspiratory loop. So it makes a nice little perfect square that's called a fixed obstruction, and, of course, that's what it is. Glottic webs would be the next one we're going to talk about. Those can be partial. Those can be complete. These children are going to present, depending on whether or not it is partial or complete, either with stridor or with complete respiratory distress. The board point I would get out of this is that it is also associated with other anomalies, and the big one that the boards like is the velocardiofacial syndrome. So remember that one. Remember also that the test for that would be to check for 22q11 deletion. And this just shows you an example of what we're talking about. This is a partial web. So what happens as the infant is developing in utero, that there's just a failure of recanalization. It can be supraglottic, it can be glottic, it can be subglottic, but the most common being glottic. So we're going to continue to move down into the trachea. Let's talk about something really rare, tracheogenesis. These children are born, they appear otherwise normal, but develop immediate respiratory distress and die shortly after birth. There are 3 types. I'm mentioning them so that you've heard it. I can't imagine that a board would ask you, what are the 3 types of tracheogenesis? But first type being that the proximal area is closed. The distal area of the trachea communicates with the esophagus. Second being that the bronchi meet midline and there's a fistula to the esophagus. And then the third, the bronchi communicate with the trachea separately. So you would suspect tracheal agenesis if you attempt to intubate, you're seeing the cord's just fine, but you're unable to pass that ET tube. Not from lack of experience either. And then tracheal stenosis. Tracheal stenosis, the most common way that we see this is segmental. It can occur anywhere along the trachea. The children often will present with stridor. What kind of stridor? Expiratory stridor, very good. Retractions, distress. Think about this also in that child who presents with recurrent or prolonged croup, because this can certainly be an etiology. And then tracheomalacia, this is the same thing that we just went through with laryngomalacia, except we're talking about the trachea. So it's just a floppiness or flaccidity of the trachea. And the differentiation being that with the trachea, the collapse occurs with expiration. Symptoms can be very minimal. Symptoms can be respiratory distress, life-threatening. They may have stridor at birth with tracheomalacia, but the more common scenario is that the child is several months old and has developed a cold, or the activity of the child is starting to increase. So that's when you're really going to notice that expiratory sound. And again, just like laryngomalacia, they've got to be awake and alert and breathing. If we're ventilating for them, we're distending it, we're never going to see this. So just like laryngomalacia, most of the time, nothing needs to be done. Really severe cases, of course, we can do stents. That's a not great plan, just FYI. We can do it, but once you stent, that stent's there. Now we've got a child-size airway and a kid who's growing. We can do segmental resection, and we can do cartilage grafting. And this is an example of one of the worst ones that we had. Just showing, here we are, we're breathing in, we're opening up the airway, here we are, we're breathing out, and everything's closing down on us. And this is the same thing, of course, but we're just talking about the bronchi. This kid had just diffuse malacia everywhere. Inspiration, expiration. Okay, so now we're going to move into the lungs. First one we're going to talk about is congenital lobar emphysema. This is an overinflation of a particular lobe. This can occur because there is a specific defect within the lobar airway, or that the parenchyma simply has an increased number of alveoli. The most common place that we're going to see this is the left upper lobe, but it can occur anywhere. And the children can present from absolutely normal, breathing just fine, to respiratory distress. Chest x-ray is, I'm going to show you. How about this? So this is a nice example, not in the left upper lobe. So you see the right upper lobe, you see it distending across the midline. You see shift of the mediastinum away from the lesion. This is a space-occupying lesion. You see compression of the left upper lobe. You also see compression of the right middle lobe. So this right upper lobe is distended, space-occupying, and pushing everything out of its way. What you may or may not be able to see is that there are markings within that lung, and you've got to look really close. They're sparse, but there are markings there. And so that's really important, because your knee jerk when you look at that would be, oh, that's a big bad tension pneumothorax. I need to put a chest tube in that. That would be the worst thing you could do, because you're sticking a tube in the lung. So then you're going to get fistula and problems. So as far as treatment, if you've got a child who's sitting there, has this, but they're breathing just fine, then you're going to manage conservatively, and you're just going to watch, and oftentimes this will resolve. However, if they're in respiratory distress, then the treatment would be lobectomy. Prognosis does appear good for this particular anomaly, but there's just not a lot of data about it. The next one is pulmonary hypoplasia. This is a very common cause of neonatal death. We see these children present at birth with respiratory distress, often associated with premature rupture of membranes, premature delivery. And how well this child's going to do is going to depend on what else is going on. So if all we've got is pulmonary hypoplasia, the child often will do well. However, if we've got other anomalies associated, that's when we're going to see problems. So In less severe cases, oftentimes we can ventilate the child until we have adequate lung growth. ECMO is also an option. So this is an example of someone who obviously did quite well. This is a big girl. But you can see that we've got herniation of the lung on the left side across the midline, and we've got this very tiny little right lung with elevation of the diaphragm there as well. And you can see that elevation again there. Okay, an additional anomaly would be scimitar syndrome. This is really rare. I can say I've seen this once. Wow. So the pulmonary venous blood from all or part of the right lung is returned to the IVC, just above or just below the diaphragm. And if you do a contrast study, it looks just like a little sword, hence the name scimitar syndrome. There's an adult form and then there's an infantile form. The adult form has a very small shunt, hence a very good prognosis, but the infantile form has a high mortality because there's a very large shunt that occurs there. Okay, so I'm not spending a whole lot of time on any of these. I want you to know that you've heard them and you should be able to pick out these little points that I'm giving you should the boards throw these at you. But if they do, it's going to be very classic because remember, these are rare. Pulmonary AVMs or arteriovenous fistulas. This is a right to left shunting of systemic blood into the pulmonary veins, left heart. These children can present most commonly with hemoptysis or exercise intolerance. Remember, if you see an AVM, think about other anomalies such as Rendu-Osler-Weber syndrome. This is the most common. About 20% of these patients will have pulmonary AVMs. Treatment for an AVM would be ablation with angiography. You can talk to your interventional guys about putting coils or clotting this in some way. And then if that's unsuccessful, then removal. So this is an example of that, and you can just see how the contrast is filling, going into, and then coming right back out of. Okay. And then sequestrations. Boards like this particular topic, so I'm going to spend a few seconds here. It's very uncommon, as you can see, 0.15 to 6% of all pulmonary anomalies. And it is a mass of non-functioning pulmonary tissue. During that development, it becomes segregated from the main tracheobronchial tree. It has its own little separate blood supply that comes directly from the aorta. It's systemic blood. And there are two types. There's an intralobar and an extralobar. The intralobar is contained within the lung proper. It's encircled within the viscera that's covering the rest of the lung. That's the most common one that we see. An extralobar has its own separate visceral covering. It's completely separate from the normal lung. So what is it? It's essentially sequestered tissue that is embryonic, it's cystic in nature, and it absolutely has no function as far as ventilation. It can, however, become infected, and often does. Most commonly, we're going to see these in the lower lobe. As I said, it's got its own arterial supply that's going to come off either the thoracic or abdominal aorta, so systemic blood supply to this. With intralobar, there is no pleural separation. We just talked about that, usually in the lower lobes, can occur other places, and I'll show you an example of that. The pulmonary veins drain into the pulmonary system with the intralobar, and these are usually diagnosed later on in life. This is your adolescent, your late childhood diagnosis. Extralobar is usually left-sided. It can occur anywhere, but the most common place that we're going to see this is left lower lobe, sitting between the diaphragm and the lower lobe. Systemic arteries are small, and with the extralobar, venous drainage goes through the systemic circulation as well. This one we often see other anomalies associated with it. With extralobar, most are diagnosed before 2 years of age. Again, like most pulmonary anomalies, more common in males. And infection is less common in this particular type, but we can see abscess formation. So chest x-ray, and this is, I'm putting in buzzwords for y'all. So chest x-ray is going to show triangular shape density, typically in the lower lobe area with displacement of the normal markings. And that would be a classic scenario for the boards to put on there. CT may be helpful. You need arteriogram for a couple of reasons. That's going to confirm it because you're going to see the systemic circulation, but also so that you know exactly where those vessels are before you go in to resect. MRA can also be used. So this is an example of one that is within the pleura itself. This one doesn't look classic at all, but it's a nice example. This one is far more classic. And you see here, triangular shape density. You see the blood supply coming directly off the aorta. This is classic. And that's just an enhanced view. Okay. So bronchoscopy can be performed, but it's absolutely not helpful. There's no communication with the pulmonary tree, so even if there's a great big abscess sitting there, we're not going to see purulence within the airways. Treatment, of course, is resection. We do have to know exactly where the blood supply is before we go in. And then if we choose not to do that, what we're going to see is just recurrent infection, abscess formation. Okay. The next anomaly that we're going to talk about is bronchogenic cyst. This one's fairly common as well. So we all know during embryogenesis there's this budding and branching that occurs, and this is when the cyst will branch off, and they just can move along anywhere they'd like. They can be extrapulmonary, they can be intrapulmonary, they can migrate down into the abdomen. This, as I said, is one of the more common ones that we see. Diagnosis can be confirmed with CT or MRI. If it's within the thoracic cage, then these children can present with respiratory distress because as it fills up, becomes infected, we can see airway compromise. But more commonly, we're going to see these somewhere around the second decade of life. And that's when they're going to present with recurrent cough, recurrent wheeze, sometimes stridor if we're compressing on the trachea. And what we'll see will be this: around water density mass. It's perfectly well circumscribed. It looks like a benign lesion as soon as you look at it. If it enlarges and encroaches on the airway, then of course that's what we're going to see. We're going to see air trapping in a particular area. If we were to, say, compress on that right upper lobe, then we would have the exact picture that we saw with congenital lobar emphysema, except we've got something that's compressing it. If it occurs occurs in the mediastinal area, then a barium swallow may show it, and it may look for all the world like a vascular ring until you CT it. So the treatment for this is resection, and we resect because it has malignant potential and because it has the potential to rapidly expand and cause airway compromise. This is an example of someone within that second decade of life, 17-year-old young lady who had this nice little round density on chest x-ray, presented with recurrent wheezing and cough. And you can see here on CAT scan what I was trying to describe for you, that it's perfectly well circumscribed, very homogeneous. It just looks benign as soon as you look at it. Okay. So we're going to talk briefly about a couple of chest wall abnormalities. Kyphoscoliosis. Most of these are idiopathic. The remainder are going to be related to some sort of musculoskeletal weakness, such as neuromuscular disease or anomalies. A curvature greater than 50 degrees causes restriction that can be seen on PFTs, and this is when I'm going to start seeing them. These children can also have hypoventilation. Greater than 90-degree curvature causes cardio and pulmonary compromise. So for the average child, bracing is what's recommended. For those children with neuromuscular disease or other anomalies, this is when we talk about surgical correction. And this is just a nice example of someone that we had seen in clinic. You see a nice huge curvature. And you also see that classic restriction that we talked about. So although I can't call it, I can suggest it. How about that? The forced vital capacity should be 80% of predicted or greater to be considered normal. You see this particular child's forced vital capacity was 58%. So that is consistent or suggestive of restriction. And then a couple of other very easy ones. Pectus excavatum. Think about a cave. That's the inward bowing of the mid-sternum. Can be familial, can be acquired. Like we talked about the child with really bad malacia that's just constantly pulling in. It can be acquired. For most children with excavatum, it's normal. If it's really severe, we'll see restriction. Surgical correction, for the most part, is cosmetic. If it's a little girl that's brought into the office, I tell mom, congratulations, she'll have beautiful cleavage. If it's a little boy, then I say, well, okay, you know, you can correct it. It's not ever going to harm him. And then if we're talking about carinatum, think about a bird beak. That's a protrusion of the sternal bone. This is almost never going to cause any sort of pulmonary issues. Surgery is always cosmetic. This is a nice example of an excavatum that we saw in clinic, and you can see on lateral how very narrow his lateral film is. This is someone that we did see a little bit of restriction with. Okay. Congenital diaphragmatic hernia. This one's fairly common, 1 in 2 to 4,000 live births. It accounts for 8% of all the major congenital anomalies, so I would expect a board question on this. This is much more common. Again, more common in males, and the mortality rate here is related to the pulmonary hypoplasia that we see. So mortality can be quite excessive, up to 60%. The most common area for this is going to be the Bachdelic hernia. It's posterior lateral defect, and almost 90% of all of these diaphragmatic hernias are going to occur here. More common on the left side, your classic vignette. Infant presents with scaphoid abdomen, barrel-shaped chest, and respiratory distress. The reason for the pulmonary hypoplasia, of course, is the fact that there are intestines in the chest and the lung can't grow. Duh. Okay, chest x-ray. If you see the chest x-ray on this child, you're going to see loops of bowel in that chest. That can, for all the world, look like another anomaly, a congenital cystic adenomatoid malformation, which is tiny little cysts within the chest. But you can differentiate this by passing an NG tube and seeing that NG tube pass into those lesions. Your treatment, of course, is going to be to pass that NG tube to decompress the stomach, intubation. Remember that if you just bag this child, you're bagging full of air, you're just making his respiratory distress worse. And then, of course, surgical correction. A couple of other not quite so common. Eventration. An eventration is just an elevation of a portion of the hemidiaphragm. Affects boys more commonly than girls. Are we tired of hearing that? For the most part, these are asymptomatic, and they're just sort of picked up, and you're like, oh, cute, that's an eventration. But it usually means nothing. It can cause respiratory distress because this is an area of the diaphragm that's not working so well. But most, 90%, are asymptomatic. Another rarity is an accessory diaphragm. So I've been doing this quite a while. I've never seen one of these. It's a fibromuscular band that divides the hemithorax into two parts. Sounds very cool. I've never seen one. But if they're symptomatic, then of course we would resect that. And this is an example of an eventration. So you see the diaphragm starting here, and then when you see this little bloop, and that little bloop is the eventration. Just a weak spot where it's elevated more. Okay, so we're switching gears now. We've got a 5-year-old male who presents with excessive clumsiness by mom. He's just always falling, and he walks funny. When you ask what funny walking means, she says he walks on his toes. You have him rise from a seated position, and you see that he walks up his legs with his hands. He's got a waddling gait. Do some lab work and a CPK is elevated. Most likely diagnosis is. Just going to say I'm expecting 100% here, guys. $99, really? Okay. Somebody's messing with me, aren't you? All right. So, Duchenne's, most common form of muscular dystrophy that's seen in childhood. We see it in about 1 in 3,000 males. It is an X-linked recessive disorder. The problem occurs because of a mutation in the dystrophin gene so that we see absent or deficient protein. Most of these children present somewhere between 2 and 6 years of age, exactly like that vignette. Waddling gait, frequent falling. They have those classic physical findings that I gave you, pseudohypertrophy of the calf muscles, and then Gower sign, which is that walking up the legs. Most of the boys lose that ability to walk by around age 11, if not sooner. Cardiomyopathy is frequently seen with Duchenne's. The reason I see them, of course, is respiratory muscle function corresponds to their gross muscle function. So we see these children in good times about once a year. We follow with what's called a NIF, or negative inspiratory force. And that takes those respiratory muscles to be able to take that deep inspiration. When we see that starting to fall off, then we know we start questioning about how well is he swallowing, and we start having those end-of-life discussions as well. The most common cause of death is respiratory failure. As we get toward end stages, we start to see recurrent pneumonia secondary to aspiration. Spinal muscle atrophy is another one of the neuromuscular diseases that we see. It is the second most common lethal recessive disorder, and that gene is located on the 5q. I would know that. Muscle weakness is symmetric, and the proximal muscles are usually affected first. These children do not have an elevation of the CPK, and they have no sensory or intellectual deficits. Most of these children can be diagnosed by gene mutation screening, and this is all new stuff since I was a fellow, so this is all cool. And there are 3 types. Some places say 4 types, but we're going to go with 3. The most severe being type 1 or Werdening-Hoffman. These are the children that present before or at around 6 months of age. They've got tongue fasciculations, they've got feeding problems, they're very weak, and most of these children will die before the age of 2, secondary to respiratory failure. As we move down through the types, we see later diagnoses and less severity. So type 2, of course, we're going to see somewhere around the age of 2 that we start losing the milestones we achieved, and somewhere early teenage years, these children pass. And then type 3, we see a much later diagnosis, somewhere between 2 and 17 years, and eventually they're unable to walk independently. Okay, and then myasthenia gravis, this is very rare in children, but it is brought forward because it is the most common primary disorder of neuromuscular transmission that we see in children. It's a reduction in the number of postsynaptic receptors for acetylcholine. So we don't have as many, therefore they're less sensitive. And there are 3 types: neonatal, congenital, and juvenile. Neonatal occurs when the infant is exposed to a transplacental passage of maternal acetylcholine receptor. And this one will get better as those antibodies clear. Congenital has a variable age of onset. Of note, they do not have circulating antibodies. And then the juvenile acquired autoimmune. This one actually affects girls more commonly, and almost all have circulating antibodies. So the first one does, the last one does. That congenital does not. Help you to distinguish. Diagnosis is made by giving anticholinesterase medication, such as edrophonium or neostigmine. I read prior to this talk that that's becoming much more difficult to come across, though. And you can see transient improvement when you administer this. Thymectomy can induce remission. Plasmapheresis, if they're really bad, you can get some short-term relief with that by removal of those antibodies. Okay. So that's all the boring stuff. Yay. Now we can talk about some fun stuff. All right, so infections is where we're going to go next. Upper respiratory illness. This you're going to see as a general pediatrician over and over and over. It is the most commonly occurring illness. We see it very commonly in the fall and winter when school starts and moms work and they send their sick kids to school. Yeah, that's what I blame it on. But there are risk factors: daycare, overcrowding. Viral disease is the most common etiology. And of course, it can be rhino or Coxsackie or adeno. It doesn't matter which one. Because they're going to present exactly the same, right? Low-grade fever, runny nose, cough. Tommy's killing me for that. Viral shedding, which peaks around 2 to 7 days, right when you're sending your kid back to school so my kid can get it. Always. So really, what do you need to make the diagnosis of this? Good history, good physical exam. You really don't need lab work to diagnose common cold. But do keep in mind that the common cold causes all sorts of complications, such as otitis, sinusitis. If it's an asthma patient, they're probably going to exacerbate and can progress to pneumonia. The little caveat at the bottom is sort of the FYI. Just because it's green doesn't mean it's bacterial, doesn't mean it's sinusitis. Early on, it can be green, and that's A-okay. As far as treatment, if you were given this classic vignette of a common cold and your choice was parental reassurance, thumbs up, great answer. Sometimes antipyretics, if they've got fever, will help. Decongestants, antihistamines is never the right answer. You can decrease ciliary motility, decrease mucus clearance with your antihistamines, so that's never your answer. Nor is cough suppressants. Okay, so we said sinusitis could be a complication, so let's talk about that for a little bit. Most common causes of bacterial sinusitis: strep pneumoniae, moraxella, non-typable H. flu. These children present with cough, often worse during the day, and when they lay down at night, they're going to have nasal discharge. And you're going to think about sinusitis if they come in with these symptoms that have lasted longer than what you would expect for the normal common cold. 7 to 10 days, they're still going. That's probably not a cold. So you can confirm your diagnosis if for some reason you felt you needed to with a Waters View X-ray. If you just wanted to radiate your child, you can do it with a CT of the sinuses. And if you really wanted to be nice and cruel, you can actually get a culture. Of course, the only way to do that is by an antral puncture. So obviously, we're going to save that for those that really need this, those that have life-threatening illness, they're immunocompromised, etc. Sinusitis can also have its own set of complications. We can see orbital cellulitis. We can see osteomyelitis as that infection invades backwards into the bone. If that occurs over the frontal sinus, that's called a Pott's puffy tumor. We can see erosion through the bone, and we can see the development of meningitis or even an epidural abscess. These, of course, are late stages, but it can occur. Treatment, of course, would be aimed at the most common bacterial etiologies. So we're thinking about amoxicillin plus clavulanic acid, macrolides, etc. Treatment duration is pretty controversial. Some people say 10 days, some people say 21 days. I think duration of symptoms is going to dictate how long you're going to treat. And then as far as your boards, if you get some crazy vignette about a poorly controlled diabetic, has this black eschar that's on the nasal turbinate, you need to remember that sinusitis can be caused by other things. It can be fungal. You need to think about mucormycosis in that particular scenario. Now, this is an example of a kid no, I'm kidding. I didn't just feel like radiating. This is a patient who has cystic fibrosis, actually. But just an example of how well the CT of the sinuses can show you the extent of the sinusitis. Everything that is here should be black. It should all be air. But, of course, it's completely full of mucus. No, I don't just radiate for the fun. I was kidding. Okay. Acute pharyngitis. Another thing you're going to see a lot of. So we typically see this in school age, 4 to 7 years, very uncommon under 1 year of age. Keep in mind, and I've even bolded it for you, the most common cause of acute pharyngitis is viral. The most common bacterial cause is group A strep. But this is only about 15% of all cases of acute pharyngitis. Sometimes you can distinguish this on presentation. If they come in with a lack of upper respiratory symptoms, they've got petechiae, erythema, that's probably strep, but I would still advocate that you prove it. And diagnosis is made with the rapid detection assays, very quick in the office. Strep has its own set of complications. Rheumatic fever, which is preventable if treated within 9 days. And then post-strep glomerulonephritis, just remember that even if you treat, you can still develop. Treatment is with oral penicillin, IM, if adherence is a concern or if the child is vomiting. The plus is for giving that screaming kid the shot is that it can shorten the disease course by about a day and a half. And they don't have to take that yucky medicine. Erythromycin or clindamycin are alternatives. And of course, what's the first thing mom says? I'm a mom, I know I would say it. How soon can my kid go back to school? The next day after you've started treatment is the acceptable answer for that. So other complications of pharyngitis, retropharyngeal abscess. This can occur after pharyngitis, can also occur as a result of penetrating trauma. What are we talking about? We're talking about that kid who's running around with a pencil in their mouth and never run with things in your hand. But they will present with abrupt onset of high fever, severe throat pain. They're holding their neck out, hyperextending, drooling. This is a medical emergency. Treat with nafcillin, Clinda, and if it is fluctuant, then we would IND that abscess. And then a peritonsillar abscess can also occur. This is almost always due to group A strep. Anaerobes can be an etiology, but almost always group A strep. And these patients present so classically. High fever, horrible throat pain, and this hot potato voice. If you've ever heard it, you know exactly what I'm talking about. But if you've ever put something in your mouth too hot and tried to say this is too hot, that's a hot potato voice. You also very classically will see deviation of the uvula to the opposite side, away from that abscess. And treatment is with penicillin as well as IND. So then we're just going to diverge for 1 second, and we're going to talk about indications for tonsillectomy and adenoidectomy. So for tonsillectomy, very stringent recommendations, as you see. So recurrent tonsillitis, okay, but they're actually very specific about it. So 7 episodes in the past year, or 5 episodes a year for 2 years, or 3 episodes a year for 3 years. So they're not strongly advocating that everybody get their tonsils taken out. If they've got severe adenotonsillar hypertrophy, sleep apnea, or if you've got unilateral enlargement and you're concerned about tumor. So that's your indications for tonsillectomy versus your indications for adenoidectomy, which I feel are fairly broad. So persistent mouth breathing, chronic repeated otitis with effusion, adenoid facies, or recurrent nasopharyngitis. Okay. So let's talk about croup for a second. Laryngotracheobronchitis. You're going to see a ton of this. You've probably already seen a ton of this. Characterized by varying degrees of stridor, cough, and is one of the most common causes of stridor that you're going to see. Has the biphasic prevalence, so we get that first peak in the fall. We're just about to get into that. And then the second peak in early winter. Remember, etiology for croup, paraflu, types 1 and 2 are the majority. but can be caused by other viruses. More common in males than females. Overall, this is a fairly common thing. About 3 in 100 children. Presents between 3 months and 3 years, peaking somewhere in the second year of life. And the clinical presentation is just classic. I know you've all seen it. These kids start with upper respiratory infection. They may have a little low-grade fever, and then boof, all of a sudden they've got this barky cough. They've got this horrible stridor. Mom comes running in the middle of the night. Kid looks fine because mom ran through the cold air. She looks horrible. She's all, ah. But the symptoms are often worse in the middle of the night, or if the child gets agitated because mom's running through the middle of the night, you know. So as far as what you're going to see, it depends on how bad it is. But often it's very classic. You know, sitting where you are, that child in triage is a croup. You hear it, you know what it is. So barky cough, often stridor. Stridor can be biphasic. That's a kid you really got to take a look at. They can be retracting if they're in distress. And like I said, that diagnosis is usually made before you've ever seen the patient. But sometimes there's questions. The history isn't quite consistent, so you can get neck films. And remember, just the classic steeple sign is diagnostic. Okay, so as far as treatment of croup, in the home setting, we're going to do things like humidification, tell mom to take the child out into the cold air, go in the bathroom, steam it up. If they've made it to you, then of course what we're going to do is racemic epi, and there's the dose for your own personal use. Steroids will usually shorten and modify the severity, so that's often what you're sending the child out with. Do remember that if you do racemic epi in the acute setting, that you do need to observe for rebound and monitor that child for a while. A totally different scenario is something called spasmodic croup. This does not have an infectious etiology usually, but the child wakes up in the middle of the night, has this barky cough, stridor, looks for all the world like croup, but the next day the kid's great. He's running around playing, you know, typical kid. But then the next night it happens again. It's felt that GE reflux may be an important component associated with this. We've also talked about segmental tracheal stenosis could be an etiology for this. Okay. I expect 100% on this one too. Don't mess with me. 3.5-year-old female comes in. Acute onset of high fever. The child is drooling. Has inspiratory stridor. She's sitting, tripoded, chin extended, obviously distressed. Most appropriate treatment for this patient is really? What are y'all doing? Y'all aren't awake, are you? Do I need to like sing and dance or something? What? Okay. What are we talking about? Epiglottitis. Come on. True pediatric emergency. Relatively uncommon. I'll cut y'all some slack. Y'all are all young babies. Since the hip vaccine. But this is an infection of the epiglottic, supraglottic airways. Usually, most notoriously caused by Haemophilus. But in today's world, we've seen Strep pyogenes, Staph aureus. Incidence is very low, 0.3 cases per 100,000 in today's world. Differentiated from croup because these kids are sick. They are sick, tripoding, leaning forward, tongue sticking out, trying to get that airway, high fever, drooling. If you see that cherry red epiglottis, it's diagnostic. If you saw that outside of an OR setting, shame on you. Never examine this kid in the office because once you get this kid agitated and upset, he can go into sudden respiratory distress. So the right answer to that was leave them alone. Send them to the nearest anesthesiologist, ENT, so that they can do this in a controlled setting and establish that airway. Treatment is with ceftriaxone or cefotaxime. Something a little bit similar, bacterial tracheitis. These kids are usually less than 3. They present with really high fever, that typical brassy, barky cough, but then they just rapidly deteriorate, requiring intubation. This is often caused by staph, so of course our treatment's going to be aimed at that with nafcillin, usually for 10 to 14 days. Intubation is typically 3 to 5 days until you hear air moving around that ET tube. That's your safe point. Okay, bronchiolitis. We see lots of this too, particularly as the winter is coming. Aren't we ready? Yes. I don't know how many of y'all from the South, but it has just been horrible this year. So anyway, inflammation of the bronchioles. Let me get back on track. Usually a result of viral illness, usually RSV. So we see this in our young population as being a bad etiology, birth to 24 months. Can occur at any age, of course. Peak incidence 2 to 8 months. And usually in the winter months, depending on where you live, this can occur year-round. There are some risk factors for having really bad bronchiolitis, and they're listed here for you. The ones I would point out: school-age siblings, multiple births, low birth weight. These are the children who are probably not going to do as well as most. So what do we see? We typically see 1 to 4 days of clear, profuse rhinorrhea, low-grade fever, and then somewhere around day 5, they sort of present with distress. It might be mild, can be severe. They often have cough, wheeze. They can go on to develop poor appetite and feeding and dehydration simply because they're working so hard to breathe. As far as physical findings, we can see hyperinflation. The pathognomonic finding that I go with are those inspiratory crackles, but we can see wheezing, decreased air entry, etc. So your initial diagnosis, of course, will be clinical. Your gold standard would be a viral culture, but by the time you got that back, who knows where anybody is. So we typically rely on the more rapid tests, such as the ELISA or the DFA, close to 90% as far as specificity and sensitivity. So we're going to get our answer quick, and it's probably accurate. As far as chest x-ray, keep in mind that about 10% of them can be normal, so that may or may not help you. You can see pretty much anything. You can see hyperinflation, atelectasis, or even interstitial infiltrates. Okay, and I include this one because I thought it was a very helpful one, particularly for anyone who's doing acute settings. So which child do we send home and which child do we keep? And the important point, I mean, a lot of these are no-brainers, but the important point of this one being that if they cannot maintain a normal oxygen saturation while they're feeding, that is the single best predictor of disease severity, the single best predictor of which child needs to stay in the hospital. Your treatment, of course, is supportive. If they're hypoxic, you're going to make them not hypoxic. And pretty much that's it. If they're dehydrated, you're going to rehydrate them. Bronchodilators, still very controversial. My take on that is try it. If it helps, great. If it doesn't, don't continue to do it because it's not making any difference. But steroids, antibiotics, not routinely recommended. Okay. And then we're going to digress a little bit more. We're going to talk about pneumonia. So in our really young, the diagnosis of pneumonia is very difficult. I've yet to find a grumpy, irritable, sick 2-year-old who will say, so I can hear those changes. They just won't do it. They did come up with some guidelines to sort of help us, particularly in the very young, under 2 months of age. And so those guidelines are, if they're breathing really fast, they've got cough, they've got crackles, decreased breath sounds, these increase the likelihood of pneumonia. If they don't have fever, they probably don't have pneumonia. So it's not as specific, but if it's absent, that's a nice little marker for you. The only thing I'm going to say is if you look up, we're talking about tachypnea, and we're saying that increased respiratory rate would be something that would increase your likelihood. But you do need to remember that fever will increase your respiratory rate by 3 to 4 breaths per minute per degree of elevation. So fever alone can cause some degree of tachypnea. Okay, so who do we x-ray? Everybody's concerned about radiating our children. Who do we x-ray? If they're under 5 years of age, they've got fever, a high white count, and no source, that's somebody who probably warrants it. If your clinical findings are not clear cut, if you're thinking that the child has an effusion, or if they are not responding to therapy. So what are we going to find? A screaming kid. No. Well, a lot of times, yes, that's what we're going to find. But we can find inspiratory crackles. We can find bronchial breath sounds. We can find egophony or bronchophony, dullness to percussion, tactile fremitus. I would start that around 5 because those little ones aren't so good at helping you with that. So as far as etiology, presenting features can be dependent on what's causing it, specific host factors such as underlying disease processes, and how severe their presentation is. But unfortunately, you're not going to look at a child, you're not going to listen to a child, and you're probably not going to x-ray a child and go, oh, I know what that is. That's this kind of pneumonia or that kind. No, it's probably not going to work that way because all these things sort of overlap. There are a few little tips, and I've given them here. So if you've got a really high white count and you've got a really high fever, that sort of pushes you toward bacterial. Remember that blood cultures in the outpatient setting are not routinely recommended for pneumonia. It's going to get you a lot of callbacks and a lot of false positives. We don't routinely recommend testing for the specific etiology unless for some reason they're not responding. And remember that SED rates also aren't really going to help you. Okay. Now through this question in, because it's got a lot of what I call buzzwords, something to sort of help you read this one really quick and pull out what's important and get the correct answer. So we got a 3-month-old, and I'm going to pull out the important stuff here. Repetitive staccato cough since 3 weeks of age. The child has tachypnea and intermittent wheezing. He had conjunctivitis within the first week of life. He does have a family history of asthma. X-ray, physical exam, the child is afebrile, but he is wheezing, and X-ray shows only hyperinflation. Most likely diagnosis is okay. Yeah, chlamydia. I'm just going to ignore those other people. I know y'all are messing with me. I know you are. Okay, so just to look at this for just a second so that you can see what I was saying. When you see an infant with staccato cough, who's wheezing, who had conjunctivitis, that is chlamydia until proven otherwise. I don't care what else they put in that vignette. I don't care if they said the child had a normal x-ray or had atelectasis on x-ray. That alone is chlamydia until proven otherwise. So that's what I'm talking about, things you've got to look for on these questions. Okay, so we're going to talk just a little bit about the different types of pneumonia. Strep pneumoniae often presents as an abrupt infection. These children are febrile, they're coughing. Oftentimes they're coughing to the point of throwing up. They can just be throwing up. Physical exam, you can hear anything that you would hear with a typical pneumonia and crying. These children often can develop sterile effusions. Remember that these effusions are sterile. Most of the time, they require no intervention. They're going to resolve spontaneously. The only time I would say worry about a pleural effusion would be if they were febrile, they responded, and the fever came back, and the effusion is still present. At that point, you need to think about empyema. And at that point, you would consider thoracentesis and chest tube placement. Strep pyogenes, what's important about strep pyogenes? Nematocils. That's what you need to put with this. So it's going to, for all the world, look like a pneumococcal pneumonia. However, strep pyogenes develops nematocils. They're common, they disappear spontaneously. Strep pyogenes can have complications such as abscesses, empyema. Treatment for this is with penicillin. And then anaerobic infections in children, pretty rare. But if you've got a history of a kid who's had some loss of consciousness, such as seizure activity, and then development of pneumonia, that's when you would think about this, some time when they weren't controlling their own airway. Classic sputum is strong, putrid smelling. Treatment is with clindamycin. And then Staph aureus, nematocils. Think about this now. Nematocils with staph as well. And so the classic, where are we going to put staph in a vignette? Right here. The patient had a recent URI or recent flu, then develops fever, cough, tachypnea, chest x-ray shows nematocils. You need to think about staph in that scenario. So staph, not common, but the complications are often serious. Abscess, empyema with staph as well. Treatment with nafcillin or vancomycin if you're in an area that is high prevalence of MRSA. This is a nice example of a nematocil, just to show you what we're talking about. Okay, and then the most common reason that we're all going to see pneumonia in kids, viral. And oftentimes this is going to be preceded by upper airway symptoms. They've got the runny nose, stuffy nose, low-grade fever, and then they develop the non-productive cough, wheezing. Chest x-ray shows those classic, radiologists love to call them perihilar infiltrates. For these children, treatment is supportive. Rehydration, oxygen if necessary. And then we're going to move on to fungal infections just real quick. I'm sure this has been covered in your ID section as well. Histo, we see in the Mississippi, Ohio River valleys. Put those together. Mississippi, Ohio River Valley, histo. Most commonly what we see is hyaluradenopathy, often calcified. We may see those calcified granulomas within the lungs. If you see splenic calcifications, ooh, you are in like Flynn. You know exactly what you got. But those are pretty rare. Normally for histo, we don't do anything. No treatments needed. It is what it is. And like I tell the families, this is like a scar. We've laid down calcium. It's like a scar. It's going to be there. Coxy, tie Coxy and the Southwest. Tie those two together. So you're going to get the story of child recently traveled to Arizona, now back with. They can have skin manifestations such as erythema multiforme, enodosum. You diagnose Coxy with complement fixation titers, and the treatment is with fluconazole or Info-B. Treatment is reserved for those that are not self-limiting or not resolving. Even if it's self-limited, the child may be left with thin wall cavities as a residual effect. And then blasto, there's a couple of things here, but if you can just put B and blasto, then you're probably going to get it because something in the vignette's going to help you. It's common smack down the middle, central, southeast, mid-Atlantic states. Chest x-ray shows broad mass-like infiltrates. The sputum is going to show large, broad-based, budding yeast. Lots of bees there. It likes to disseminate to bone. And treatment is with ITRA or Ampho-B. There you go. This is a nice little example of these mass-like infiltrates that we're talking about. You see fine, not fine. Easier to see on this one. So that would be sort of classic for blasto. Okay, and then just since we're saying fungal, let's throw this one in here. Allergic bronchopulmonary aspergillosis. What do you need to remember about this? Couple of things. One, it's not an invasive infection. It is an allergic reaction to Aspergillus. They have type 1, type 3 reactions. Your studies that will help you to diagnose this, an IgE that's really high, typically typically over 1,000. And a classic scenario would be previously well-controlled asthmatic, now poorly controlled, has chest x-rays with fleeting infiltrates, it's a nice little buzzword for you, and cough productive of brown plugs. If you get that much, you should nail it. Treatment for ABPA is often steroids, prolonged treatment. Okay. All right. 19-year-old presents to his local college infirmary. This is a dorm dweller. Has fever, cough, and chest pain. Before you walk in the room, you're flipping through the chart and you say, oh, he was just here a week or two ago with sore throat. The most likely etiology is staph, Klebsiella, Legionella, Chlamydia, pneumoniae, or an atypical. I like about half of y'all. Seriously. Okay, so what we were talking about was an atypical pneumonia. Okay. So we're going to talk about the most common one first. I didn't put that one in there because that would have been too easy. So mycoplasma, common cause in children over the age of 5. These kids present with fever, headaches, sore throat, non-productive cough. Chest x-ray always looks worse than the patient. Remember to put things like bullous meningitis, neurologic changes, and mycoplasma in your mind together because the boards like to pull out things like that. Definitive diagnosis, IgM antibody, and treatment with macrolides or doxycycline. The one that I put in the vignette, chlamydia, which is the TWAR pathogen, causes epidemic pneumonia. That's why I said dorm dweller. In children and adolescents, very similar to mycoplasma, they see sore throat 2 to 3 weeks prior to the onset. Treatment is the same, macrolides, doxycycline. Okay. So I'm going to throw another question at you. A 10-year-old African-American female comes to your office for a routine checkup. She has a past history of asthma, currently being treated with an albuterol meter-dose inhaler on an as-needed basis. She uses this at least once a day. She says she wakes up from sleep about 3 to 4 times a week because she's either coughing or wheezing and has to use her inhaler. Her past history is noteworthy for the fact that she's been in the hospital about 1 to 2 times a year, that she visits your emergency room about 6 times a year. She has 2 prior ICU admissions at age 6 and at age 8. She has on several occasions been treated with inhaled steroids. She'll usually take it for about a month after she leaves the hospital. She can't really tell a difference and she stops it. She requires oral steroid burst about every 6 to 8 weeks, usually treated for about 3 to 5 days. Today, her exam is normal, and her spirometry that you obtained in office shows an FEV1 of 59%. So based on the guidelines, and we can classify, because currently she's on nothing but PRN bronchodilator, how would we classify this patient? Mild intermittent, mild persistent, moderate persistent, or severe persistent? Okay, that looks a little better. Absolutely. This is a severe persistent child. She has daily symptoms. Okay, so asthma is a chronic inflammatory disorder. So what we see is an influx into the airways of mast cells, eosinophils, and that inflammation, which is the hallmark and the underlying problem with asthma, is associated with all the signs and symptoms that we see. The airway hyperresponsiveness, the airflow limitation, the symptoms that they come in with, the wheezing, the shortness of breath, the chest tightness. The important point about asthma is inflammation and chronic. This is a chronic disease. They're not going to outgrow asthma. Your diagnosis of asthma is made based on history and based on physical exam. That should be sufficient to make your diagnosis. They're going to give you the common symptoms. They may or may not give you nocturnal awakenings like this young lady did. They may or may not be able to tell you what triggers them, but you most likely can pin down one or two. The most common ones being weather change, upper respiratory illnesses, or exposures such as smoke, strong perfumes, etc. And the other important point that you need to get from your history is response to asthma-specific therapy. I take a breathing treatment, I get better. On physical exam, if they come in like this young lady and she's having a great day, it can be completely normal. You can see all the other things that you would see in the throes of an exacerbation, such as hyperexpansion, accessory muscle use, or wheezing. So I threw in a little something about spirometry based on previous comments that they wanted a little more about this. So what is office spirometry? The things that we look at to help us gauge where patients are: forced vital capacity, or FVC. That's the volume of gas that the child can blow out as forcefully and rapidly as possible after taking a deep breath. That gives us an idea of how much volume is there, okay? The FEV1 is that volume that they blew out within the first second, and that's a marker of large airways. And then your mid-flows, forced expiratory flows, 25-75, this is the average rate of flow during the middle half of that same maneuver. So that gives us a marker of where the small airways are. So these are the things that we typically look at. It measures volume versus time. It can easily be obtained in a specialist office. In a primary care setting, this may take a little work. By someone trained to do it, it takes about 10 to 15 minutes. And most children 6 and up can do this. A 2-year-old cannot do this. In asthma specifically, those values can be completely normal during times of wellness. During times of illness, however, we're going to see classic obstruction, and that is decreased FEV1, decreased mid-flows. And depending upon how badly they're obstructed, that forced vital capacity, the total volume, will either be normal or reduced. It will be reduced with severe obstruction. Okay. So then as far as our goals of therapy, of course, we want to prevent their symptoms. We want normal lung function. We want them doing everything that every other kid does. That includes PE and recess. We want to reduce the number of exacerbations. We want to keep them out of the ER. We want to keep them out of the hospital. And we want to do all of that with the minimal amount of side effects that we can. As far as the really young, this can be somewhat challenging. And I say every year I'm going to take the statement out. I think I am next year. But when we see children, often we used to see them come in with cromolyn, because cromolyn had a great safety profile. It just didn't do much. So the kid was still sick when we would get them. That is almost impossible to come by, number one, and almost never started anymore. So I'm going to take that one out, so just ignore that. But remember that response to therapy should be monitored. So if you start something and they come back and they're doing fantastic, you want to get them on the lowest dose that will keep that control. Some important points for managing those school age and adolescent. Remember that if you're going to send them for spirometry, that your technician needs to know childhood norms. You need to use the right reference range. You cannot compare a 7-year-old to an adult and come up with an appropriate reference. You need to involve that child in establishing their treatment plan, because the 15-year-old who doesn't like the taste of a medicine is never going to use it. So encourage involvement with particularly the adolescents, and encourage activity in sports. Now, there are a handful of asthmatics that we follow that we will pull. But the vast majority of what we see, we are encouraging them to do everything that every other kid does, which includes going out for recess and PE. And make sure that you give all these kids an action plan so that they know what to do should problems occur at school or at home. The use of peak flows can be helpful. So acutely, you're in the ER urgent care setting, you can assess how severe the child is. For short term, you're making changes in therapy. You can use that to help you evaluate how successful is this therapy. You can also use it, and this is where I find myself really using it, to establish relationships to triggers. They come in, I don't know what triggers me, I just get sick. Well, there's got to be something. So we can use peak flow to help us find that something. And then long term, particularly if you have someone who's a poor perceiver and they come in and they're really bad and they say, well, I've been fine. You probably haven't been fine. You just didn't know how bad you were. And so peak flow can be used to help you and help them understand their symptoms better. And then it can also be used within your action plan. A couple of other issues with asthma, sinusitis. The important point being, don't treat the x-ray, treat the patient, because there is a high incidence of abnormal films in the asthmatic population. Inflammation in the lower airways, there's inflammation in the upper airways. It's all one airway. So you will see mucosal thickening and inflammation. That doesn't make it sinusitis. Remember that reflux in the little children can cause them to wheeze. Everything that wheezes is not asthma. So remember, reflux can mimic asthma. And remember that certain medications can cause reflux, which will make their asthma worse, particularly theophylline. And then for those patients with exercise-induced symptoms only, that is not a 3-year-old. 3-year-olds exercise from the time they get out of bed to the time that mama forces them back in. That is not that child. I'm talking about your 16-year-old who's on the running team, who goes out and when I run 2 miles, I start to wheeze. That's what I'm talking about. For those patients, pre-treatment with a short-acting bronchodilator can be sufficient therapy. And we're going to ignore cromolyn on there. Okay. If you've diagnosed your patient with asthma and they come in and they are no better, what do? Here's what you need to do. Do I have the right diagnosis? Could it be any of these other things that can mimic the same signs and symptoms? Could it be CF? Could it be vocal cord dysfunction? Could it be sleep apnea? Is there something in the environment that's preventing me from gaining control? Is mom sitting there blowing smoke in the child's face 24 hours a day, and that's a trigger for him? Does this child truly have sinusitis, allergic rhinitis that's not controlled, postnasal drip that's triggering it? Could this child have reflux, and that's what's causing him to continue to have exacerbations? And then the most common reason that we see is poor adherence. Are they really taking their medications as prescribed? Are they really using the chamber as prescribed? So you need to think about those things. Okay, so I'm going to launch into this real quick. Classification. We talked about in that first vignette, where is she? And how do we classify her? And where did we come up with classification? This is where it came from. We classify based on the amount of impairment that the child is having. How much is it impacting that child's life? How often are the symptoms? How often do they wake up at night? How often do they need their rescue medication? How often does it interfere with their normal daily activities? And then, where's their lung function today in a well state? It's also based on risk. How often are they having exacerbations requiring oral steroids, which includes primary care visits, ER visits, etc. So these are your classifications, and just like I said, you can classify those patients not on controller therapy. If they come to you and they're already initiated on something, you cannot classify them. But if they're on nothing, these are what you use. So an intermittent, symptoms less than twice a week, nighttime symptoms less than twice a month, less than 2 days a week, they need their inhaler. normal lung function, rarely exacerbate, doesn't interfere with their life. A mild persistent is a little bit more than twice a week, nighttime symptoms 3 to 4 times a month, more than 2 times a week needing their inhaler, some minor limitation in normal activity, still normal lung function, probably having more exacerbations. Moderate persistent, again, we're just stepping up, daily symptoms, nighttime symptoms more than once a week, daily use of their inhaler, some limitation, their lung functions are not normal, exacerbations more than twice a year. Severe persistent, it's continual. We're always having symptoms. Now, we talked about in that vignette, and some things seemed moderate, some things seemed severe. Always go with the worst. So if you've only got one factor in there that fits severe persistent, in that particular vignette, it was her FEV1 being less than 60%. 1 point in severe persistent, it is a severe persistent. You always go with the worst. For infants, how do you make that diagnosis? So you need to think about calling a duck when the child has had more than 3 episodes of wheezing in a year, they last more than a day, they affect sleep, and the child has risk factors. What are the risk factors? Family history of asthma, allergic rhinitis, atopic dermatitis, peripheral eosinophilia. They wheeze at times other than with upper respiratory infection. Okay. So the latest guidelines came out in 2007. And at that point, they said, just as I have said, on that initial visit, if they're on no controller medications, we can classify severity. But the focus of the guidelines isn't just on calling someone a name. You're severe persistent, you're mild persistent, but rather on control of symptoms, which is really what we did in practice anyway. So our goal is to get them well controlled. They may come back not well controlled. They may come back poorly controlled. And that's what matters. Where are you in that spectrum of control? So if you look at classification, that's exactly what I told you. So we have a severe persistent. We're going to go to step 3 or step 4 and consider systemic steroids. She comes back for evaluation after you initiated your therapy. Where is she? That's what matters. You do the same thing. How often are the symptoms, nocturnal awakenings, interference with activity? What are the lung functions looking like? How often have you required systemic steroids? And then what do we do at that point? She comes back well controlled. We're going to either maintain it or consider stepping it down. She comes back very poorly controlled. Did we start the right drugs? Do we have the right diagnosis? Is she really taking them? Okay. Then what do? We step up. Okay. As far as therapy, we could probably get through this real quick. We've got quick relief and we've got controller. Quick relief is your short-acting beta agonist, inhaled anticholinergics. Note that systemic steroids are not a controller. They are a quick relief. We do our very best to avoid systemic steroids in these patients. And then our long-term controller, inhaled steroids, bleep, ignore that next one, long-acting beta-2s, methylxanthines, leukotriene modifiers. Steroids are our most effective anti-inflammatory agent that we use. Remember that there are adverse effects. I can promise you, there will be a question on the adverse effects of corticosteroids. Know them. Axis suppression, osteoporosis, weight gain, thinning of the skin, growth retardation. There will be a question on that. Know it. Also know that at moderate dose inhaled steroids done correctly are not associated with those risks. Okay, long-acting beta agonist. Little bit of controversy. I think the pediatric pulmonologist begged and they kept it on for kids. It is not a quick relief medication. It's given every 12 hours and best given in combination with an inhaled corticosteroid. Leukotriene modifiers. inhibit leukotriene production or inhibit receptor binding. They're very good for exercise-induced asthma. They're very good for asthma in association with allergic rhinitis. They are not great monotherapy, but they are a great second line. Theophylline, we rarely use it, but the board still like it. Remember that it does require serum monitoring. It has GI toxicity, and remember that there are lots of drug-drug interactions with theophylline. They love that. Asthma on theophylline, goes to the ER, gets Cipro, suddenly starts throwing up. What's the problem? That sort of thing. That's what I'm talking about. Okay, and then which asthmatics are at risk for sudden death? I use these a lot when I'm talking to families, particularly families that are sort of blowing off, taking their therapies as prescribed. Oh, it's just asthma. Everybody has asthma. It's just asthma. So who's at risk for sudden death with asthma? 2 or more hospitalizations in the past year, that child is. 3 or more ER visits in the past year, that child is. If you've been hospitalized or in the ER for the past month, you're at risk. If you're using more than 2 canisters of a quick relief medication per month, you're at risk for sudden death. So I use these in talking to the family to help them understand that this is a severe disease process. The other big one from this page is difficulty perceiving airflow obstruction or its severity. That's the one that we talked about that comes in, oh, I was doing great. I don't know how I got sick. It just poof, all of a sudden. So those patients are also at risk for sudden death, and you really need to work hard with those patients at education and helping them to understand their symptoms. We have a 3-year-old Caucasian female seen secondary to chronic cough for 2 months. She's been treated with steroids, bronchodilators, and antibiotics without any significant resolution of her symptoms. Her past history is really only noteworthy for some seasonal rhinorrhea and nasal congestion. On physical exam, normal vital signs, height and weight at the 25th. You look at her nose, she's got a little erythema of the posterior pharynx, but no exudate, no polyps, no postnasal discharge. On auscultation, she has a localized area of wheezing within the right lower lobe. Most likely diagnosis is asthma, allergic rhinitis, foreign body, immune disorder. Yay, y'all woke up. Y'all had coffee, didn't you? I know you did. Excellent. Okay, so we're going to talk about a few non-asthma causes of wheezing. So foreign body aspiration would be one biggie. Most commonly aspirated objects, of course, seeds, nuts, popcorn, but anything that can go in the mouth can be aspirated. So that includes small toys, beads, parts of Mardi Gras beads are a big one. Balloons, hot dogs. Most of the time it's going to lodge within the right main stem, sometimes the left, but the right is your straight shot. And these children will present with choking, coughing, wheezing, stridor, or they may present just like that vignette and mom has no clue because mom was not present and did not witness the aspiration. Chest x-ray can show a asymmetric hyperinflation in the area in which, of course, something is lodged. But remember and keep in mind that your chest x-ray can be normal in up to a quarter of the patients. So what are we going to do radiologically to help us figure this out? So if you have an older patient, a cooperative patient, you can do inspiratory and expiratory films. The expiratory film will show you mediastinal shift away from the foreign body or hyperinflation of a particular lobe on the same side. So what you're getting is a ball valve effect so that air comes in but it doesn't go out because there's a foreign object there, so you get hyperinflation of that particular lobe. If you've got a child who doesn't understand or isn't being cooperative, the other things you can do are decubitus films. Placing the side of obstruction down should deflate the lung, but instead what you'll see is a persistent hyperexpansion. Or you can do fluoroscopy which is essentially an inspiratory and expiratory without the child having to do it, because ultimately they have to breathe in and they have to breathe out, and you can get that on fluoro. Okay, just remember, never do blind finger sweeps. If they're less than a year of age, then we do the back blows. If they're over a year, the Heimlich. You can try jaw thrust, and if you can see it, you can try to remove it with forceps, not your fingers. If the child is unconscious, of course, we need a surgical airway. If the foreign object has passed on down into the airways, the important point from this one would be rigid bronchoscopy, because you've got to have some sort of instrumentation that can not only get there and see it, but that can get it back out. Antibiotics aren't usually indicated unless it's been there a really long time and we've got infection behind it. Okay, some other non-asthma causes of wheezing: bronchiolitis obliterans. This one's not very common. However, most commonly associated with adenovirus. About 2/3 of patients are at risk for the development following adenovirus if they're Native American. And what we see with bronchiolitis obliterans is that the bronchi and bronchioles become plugged with a fibrous type tissue, which results in hypoxia and hypercarbia. We're seeing this more commonly in our post-transplant patients, particularly bone marrow transplant, as well as lung transplant patients. Lung biopsy is what's necessary to confirm that diagnosis. Our treatment is often supportive for these patients. This is a young man that we followed for a while with bronchiolitis obliterans. You can see that he's fairly hyperexpanded, but what's important is this, and this is sort of a hallmark or pathognomonic for bronchiolitis obliterans. As you sort of roll down through that CAT scan, you'll see areas of increased markings, if I can get this to go up here, increased markings, but your next cut shows a relative paucity of markings. And so that is almost pathognomonic, areas that are heterogeneous just as you move from one screen to the next. Bronchiolitis obliterans with organizing pneumonia. Again, something not very common in children. Somebody got the great idea to rename it, of course. Must have been an ID guy. But the new terminology now is cryptogenic organizing pneumonia, or COP, just so that you've heard it. But what happens is we get thickening of the alveoli septi. We get this influx of inflammatory cells that go in there. Type 2 cell hyperplasia is what's classically associated. This can occur because of pneumonia, can occur because of a large inhalation of a toxic substance. Collagen vascular diseases can also be an etiology, and rarely, and of course I got the rare one, it's idiopathic. But they present with recurrent episodes of bronchitis that respond to antibiotics, but then it reoccurs, and you treat and it gets better and it reoccurs. And this will happen several times before the diagnosis is ever made. Steroids are the treatment of choice for this. So what you'll see with bronchiolitis obliterans with organizing pneumonia is something like this. Bilateral, nice fluffy infiltrates, looks like pneumonia. It's what we see on CAT scan. Again, nice little infiltrates within the lower lobes. And what's a board review without PAL slides, right? Yeah, put everybody right back to sleep. So really, what do I take away from that? I'm not a pathologist. What I take away from that is there's too much purple in there, right? There's too many inflammatory cells in that cut of lung tissue. And I think that's the important point. There is some fibrous tissue that you can see here, but the important point is there's too much blue. Okay, another cause of non-asthmatic wheezing would be bronchiectasis. Bronchiectasis is a dilatation of the bronchioles. It's usually irreversible, almost always irreversible. These children will present with chronic productive cough. They can have wheezing, and of course they have recurrent infections. The airways are dilated. They don't help to move the mucus forward. It just sits in there, stagnates, becomes infected. Often we see clubbing with these children. On lung function testing, they have a very large total lung capacity, residual capacity, small vital capacity. If you're taking your boards and somebody says bronchiectasis, the very first thought you need to have is the same one you have when you have nasal polyps. CF, CF, CF. Other things can do it. Chronic aspiration can do it. Immune deficiencies can do it. If they mention asthma in that scenario, then think about ABPA. The bronchiectasis is typically central with ABPA. Treatment is with bronchodilators. We've got to open those airways, and then some form of airway clearance. I've placed postural drainage here because I personally like that one, but some modality of airway clearance to move that mucus into the large airways so they can expel it. So here's another reason to have bronchiectasis, an emodal cilia syndrome. So this is a disorder of cilia morphology. They may be missing a dining arm, or their center tubules may be messed up, but some abnormality that causes them not to function and move as they're supposed to. The best known of this is Cartageners. With Cartageners, they've got sinusitis, bronchiectasis, and situs inversus, as well as reduced fertility. Remember, if situs inversus is not present, it is not Cartageners. It's just emodal cilia. The treatment's the same as you would for bronchiectasis. It looks a whole lot like cystic fibrosis, except they don't have the GI symptoms. Prognosis is much, much better. Okay, topics I don't really care for. Apnea. I'm honest, if nothing else. Common problem in premature infants. Rarely occurs in a term infant. If it occurs in a term infant, it's always pathologic. That's an important point to remember. And just as an aside to keep in mind, the rhythmic control of breathing requires that you, number one, have the central drive. Number two, that you maintain patency. And number three, that you have adequate function of respiratory muscles. So typically with young children, what we're seeing is that central drive is what's become the problem. So apnea prematurity. Apnea is defined as the absence of airflow lasting longer than 20 seconds or shorter, but associated with bradycardia or cyanosis. It can be obstructive, it can be central, or it can be mixed. For apnea prematurity, this is typically going to develop within the first or second day of life, and typically will resolve before 37 weeks gestation if they're born after 28 weeks. If the child goes a week and they're breathing just fine and suddenly starts to develop apnea, you need to think about something else. Sepsis, some other etiology. And these are things that can cause that development in a susceptible infant. So hypoxia, infection, temperature instability, narcotics, intracranial hemorrhage, etc. For apnea prematurity, we treat those infants who are having frequent, prolonged apnea, or apnea that is associated with cyanosis or bradycardia, or apneas that require resuscitation. And we're going to treat it with oxygen. We need to control their body temperature. Sometimes we need nasal CPAP. Sometimes we need methylxanthines. And of course, we monitor these children. Please remember that there is something called periodic breathing. This is not apnea. This is a normal type of respiration that occurs in preterm infants, so that they have 3 or more pauses that are more than 3 seconds, but that last less than 20 seconds in between normal respiration. Okay, so this is normal preterm. They just weren't ready to come out yet. And the other important point is apnea is not a risk factor for SIDS. Obstructive sleep apnea. I think this has really gained more popularity with the general pediatricians, and I think more and more y'all actually look for this. But the incidence is 1 to 3%. Peak prevalence being 2 to 6 years of age. Why 2 to 6 years of age? Because that's when the adenoids and tonsils are at their largest in relation to the child's airway. But other children, Downs, craniofacial abnormalities, achondroplasia, neuromuscular disorders, all these children are at risk. Often the diagnosis is delayed because Well, we don't usually take sleep histories on children. If they're restless sleepers, well, kids are restless sleepers, and so that's often kind of blown off. They don't usually present like the classic Pickwickian, I'm overweight, obese, and I'm sitting in your clinic and I fall asleep, but instead they're the skinny, wired, bouncing off the walls kind of kid. And then, of course, often if the child is going to do this, it's going to be during REM when mom is sleeping too, and so, it's just simply not noticed. Things that should prompt you to inquire and look for this: signs of allergic disease, if they're mouth breathers, if they've got obviously craniofacial abnormalities. You need to look at nasal patency, tongue size, tonsil size. We can see the development of pectus with long-standing obstruction. That would be a late finding. They can develop core pulmonality. Again, that's a late finding. You've sort of missed the boat on that one. Gold standard is polysomnography or an overnight sleep study. You can do nap studies. However, most children don't do true REM night sleeping during a nap. And so if you catch it, great, 100% positive predictive value. But if they don't do it, it doesn't mean they don't have it. So 17% negative predictive value. For most children, the treatment would be adenotonsillectomy, and that's usually curative in most. For those with craniofacial abnormalities, not always. Other things we can do: CPAP, tongue wedge resection like a Beckwith-Wiedemann kind of kid, epiglotoplasty, and for really bad ones, tracheostomy. Okay. This is a good, easy one. So the following has made the greatest impact on the reduction of SIDS: efforts to reduce maternal smoking, back to sleep campaign, home monitors, avoidance of soft material in the infant sleeping environment. Yay! There's still people messing with me though. Okay. Right, of course, it's the back to sleep campaign. Really? Somebody's gotten some moms to quit smoking? That's great. So, definition of SIDS: sudden death of an infant under 1 year of age that remains unexplained after you've done a thorough case investigation, including autopsy, examination of the death scene, and review of the clinical history. It's the second leading cause of death in infants 1 to 6 months of age. These are current statistics. Estimates of 0.5 to 0.6 per 1,000 per year. 85% occur between the age of 2 to 4 months. 95% occur before the child is 6 months of age. And then the highest rates would be in Native Americans, followed by African Americans, Caucasians, and then Asians. Some risk factors specific to the infant: being born prematurely, having low APGAR scores at birth, they spent time in the ICU, they have BPD, anemia, they've had a previous acute life-threatening event or ALT, or they've had a sibling with SIDS. Maternal risk factors: anemia, smoking, drug abuse, or a really young mom. And then, of course, the additional environmental, etc. risk factors: sleeping position, soft bedding, overheating, bundling that child too much, race, ethnicity, and socioeconomic status. All right. Drowning is the second major cause of unintentional death in children in the United States, and we see this in 2 age peaks. We see this in the under 5s. Somebody turned their back for just 1 second and it happens. And then we see it in those silly adolescent males, 15 to 25, who are, nothing's ever going to happen to me, so I'm going to do this crazy skiing on my head kind of thing. And what we see is aspiration of fluid causes a loss of that surfactant. And so they get pulmonary edema, development of ARDS if it's a near drowning, or of course death. Chest x-ray, remember, can be normal initially. So if you've got a near drowning that comes into your institution and the chest x-ray looks great, that doesn't mean that 24 hours later it will remain looking like that. CPR should be performed with the knowledge that there could be cervical spine injury. So if you're on the scene, keep that in mind. Also, drownings or near drownings in cold is good. Hypothermia is neuroprotective. And resuscitation should be continued until the child has been warmed to 32 to 35 degrees Celsius. So here's your risk factors for poor prognosis. You spend more than 10 minutes before life support is begun at the scene. The resuscitation takes more than 25 minutes, or the water temperature is more than 10 degrees. There are no good early predictors of poor outcome. Okay, so there's no way I can turn this around and tell you these are good things. All right, BPD. We see this less and less, so good job, neonatologist. But defined as oxygen dependency, abnormal chest x-ray, or persistent signs of respiratory distress after 36 weeks post-conceptual age. We see with these children increased lung resistance and decreased lung compliance. And those two things are what cause all the signs and symptoms that we see: the wheezing, the crackles, the tachypnea, the increased work of breathing. The best thing we can do would be to prevent this. So delaying birth past 30 weeks, prenatal steroids, etc. So a young child who had BPD, and I think it just shows you the classic findings that we see, the alveolar as well as interstitial changes that we see within the airways. There are environmental risk factors that play a role as well. We can look at one NICU and look at their rate of BPD versus another NICU, and we see differences. We know there are environmental differences. What are they? Infection control, nursing care, fluid management, all of these seem to play a role. Infection, immunity, PDAs, and how quickly we're diagnosing those, how quickly we're replacing micronutrient deficiencies. All of those seem to impact our ultimate outcome. Our treatment for BPD, low flow oxygen to keep saturations 92 to 96%. And if we're doing it all right, what we see is that the infant is gaining somewhere between 20 to 40 grams a day. Lasix, furosemide, can be effective in improving lung mechanics, gas exchange. Bronchodilator therapy is also helpful. There's really no role for steroids other than ventilator, but once they're BPD and they're in the outpatient setting, steroids really don't seem to play a role. Another important area is RSV prevention, and in December 2009, so is that right? I think that's right. There were some new guidelines that came out. So we say RSV prophylaxis should be initiated prior to the onset of RSV season, terminated at the end of RSV season, or according to the new ones, after the maximum eligible doses. Remember that it does not interfere with other vaccine administration, and just because you've had RSV once doesn't mean you can't get it again. Yeah, 2009, yay. So what they did in their new recommendations was they minimized the number of doses that the child can receive and simultaneously decreased the number of risk factors they needed to receive this therapy. So we now only have 2 risk factors: that they either attend childcare or they have 1 or more siblings under the age of 5. And then it gets really complicated. So you can receive up to 5 doses if you have chronic lung disease, chronic heart disease, and you're under 24 months of age, both of which lung and heart must be on therapy. Can't just have it but don't need therapy. Or you're born less than 32 weeks gestation. Or certain infants with neuromuscular disease, congenital abnormalities of the airway. Those people are eligible for up to 5 doses. Notice I'm saying up to. You are eligible for up to 3 doses if you are born between 34 weeks and 6 days and 32 weeks, and born within 3 months of the start of RSV season or during RSV season. So if you're born in April, you're not eligible. Okay. That's pretty complicated. Y'all have to look at that one. All right. New question. 8-year-old comes in with complaints of cough. She says she coughs up yellow stuff. She has some low-grade fever and some headaches. Her cough has gotten worse over the past 2 weeks, and sometimes when she coughs, she actually throws up. She's had this cough for about 4 years, worse in the morning, worse if she gets a cold. Both of her parents smoke. They smoke outside. Yeah, y'all get that. On physical exam, her weight is between the 10th and 25th. Her height's at the 10th. She has some wheezes and crackles in her upper lobes. She coughs during your exam, and she kind of gags on what she's coughing up. But really, there's no other specific findings. What test are you going to order to make the diagnosis in this child? Immune workup, pH probe, sweat test, methacholine challenge. That's some good coffee y'all got out there. All right, sweat test. So we're going to talk about cystic fibrosis. So CF is a chronic multisystem disorder. And what we see is that we don't move sodium and chloride adequately across epithelial surfaces. And this affects our respiratory, gastrointestinal, as well as reproductive systems. The predominant morbidity that we see is, of course, the respiratory disease, and it is a progressive obstructive disease. We can have, obviously, the other manifestations, pancreatic malabsorption in about 85% of the population, diabetes in about 15%, cirrhosis, pancreatitis. Chronic sinusitis, we see more close to about 85% of our patients with chronic sinusitis. They have elevated sweat electrolytes, become dehydrated very easily, and the males, 99% of the males are sterile. The women are not sterile. That's an important point. The women are not sterile. They do have a more difficult time conceiving, but they are not sterile. It is the most common recessive genetic disorder in the Caucasian population, less common in other populations. Let me please just reinforce that less common does not mean it does not occur. We recently had a family move into our area that had been told because the father was Hispanic, there was no way this child could have cystic fibrosis. That is false. So it does occur in other ethnic groups. It's just less common. Currently, we have about 30,000 individuals in the United States that are affected. So I updated this one as well. The most common presenting symptoms. As you can see, most common presenting symptoms are going to be GI and respiratory. 50% of the newly diagnosed infants in 2009 were diagnosed by newborn screening. That is a huge, yay, coup for us. We're very excited about this. The respiratory symptoms are the most common cause of premature death in these patients. What we see is that because we don't have appropriate ion transport, we have thick, sticky stuff that occurs within the airways. That leads to mucus obstruction. That obstruction then leads to bronchiectasis, recurrent infection within the airways. The most common organisms we see initially are Haemophilus, staph, but over time, Pseudomonas is our predominant organism. We can see other things as well. We can see hyperresponsive airways, or what we would call asthma in other populations. In stage, we can see hemoptysis, pneumothorax, pulmonary hypertension, and we also see ABPA, just like we see in the asthmatic population, within the CF population. On X-ray, initially we're going to see hyperinflation because of air trapping, mucus obstruction, but over time we start to see bronchiectasis develop and fibrosis, usually in the upper lobes first, but ultimately everywhere. So this is an example of someone who's more end stage, and you can see bronchiectasis here in the lower airways. The other thing that you can note is that it looks sort of like you could just take a tweezer and sort of pick out the little dots, and that's the alveolar mucus that's there. See here as well. And then on CT, very nicely shown, dilated bronchiectasis. Okay, so you're on call in the middle of the night, and the nurse calls you. You've got a 18-year-old on the floor with CF. She's got a sudden onset of chest pain and shortness of breath after she's been coughing. The most likely reason that she has this is pneumonia, pulmonary hemorrhage or hemoptysis, a mucus plug, or pneumothorax. Good. Pneumothorax, absolutely. And that's what we need to look for when that's the phone call we're receiving. You can see here the plural line. Okay, so let me just also make case in point. Newborn screening is great. We're picking up more and more children that way, and we're all very excited to have nice, healthy babies. However, it is a screen. We're going to miss some. So please continue to consider the diagnosis in a child who has persistent wheezing or coughing, recurrent pneumonia, persistent X-ray changes. The GI symptoms we see are fairly classic: loose, foul-smelling, greasy stools because they're not absorbing the fat within their diet. They're often very hungry, and despite eating way more than they should be eating, they're not growing. They can present early with meconium ileus. Oftentimes, these children can be labeled as formula intolerance because they're not growing. They've got bad diarrhea. They're spitting up all the time. And sadly, a huge chunk of our population, up to 80% of our patients, do have reflux to help confound that diagnosis. Some uncommon presentations, we can see referrals from ENT for nasal polyps. A child could present simply with rectal prolapse. Fat-soluble vitamin deficiencies, less common in today's world, but still we can see presentations of vitamin A deficiency, such as dry eyes, vitamin D, rickets, again, very uncommon but can occur. Vitamin E, skin rashes, vitamin K, easy bleeding. These still do occur. Okay, so to make this diagnosis, we need to have one or more phenotypic characteristics. In other words, one or more of these signs and symptoms we talked about, or a history of CF in a brother or sister. And I can now say, or a positive screen, plus, this is how we're going to prove it, elevated sweat chloride, 2 CF mutations, or demonstration of abnormal characteristics of ion transport across the nasal epithelium, and that's only done in certain sites around the country. The other two are much more commonly available. So for sweat tests, the only recommended and approved way is the quantitative pilocarpine iontophoresis sweat test. Things that are done in smaller centers, direct conductivity or paper patch, are associated with high false positives and false negative results. So those cannot be used as diagnostic. We have to show a chloride concentration of 60 millimoles or greater, and we do have to do that on more than one date. They will never ask you this. I am giving you this for your own benefit and knowledge. What can cause a false positive, false negative? Not board stuff, just FYI. Okay. CFTR, excuse me, that is the problem with CF. That's that ion channel that does not work. Sorry. The gene for that protein was encoded in 1989. We all thought we were going to have a cure in 5 years. Since then, what we found was that there's over 1,000 mutations that can occur in that one particular protein, not all of which cause CF. Current studies only test for 97, the most common being Delta F508. That is a good board question. We use DNA at this point for confirmation, to give genetic information for the family, to predict pancreatic status. And the other big one, with new medications that are coming out, we're now actually targeting the specific type of defect with the new medications. And so when you recert, after you pass this one and 10 years go by and you recert, you'll need to know about that as well. Newborn screening is linked to the other neonatal screening. So at the same time they do the PKU, they test for hypothyroid, they're screening for cystic fibrosis now. The most common one being an IRT, or immunoreactive trypsinogen. And if that is elevated, then they proceed to step 2 in most states. Some states repeat that, but most states go on to DNA testing there. Regardless of the modality that's tested, it's now being done in all 50 states. A normal value is considered less than 140. Other states have different cutoffs. Our state's much more on the conservative side. And the reason that we started all this is because if we start with a nice, fat, healthy baby who's never had respiratory problems and who's never been failure to thrive, by the time they're an adult, they're also showing us that they're achieving much closer to normal height, weight, less hospitalizations, better lung function. Overall, across the board, we're taking them from nice, happy, healthy babies into nice, happy, healthy adults, or relatively healthy. So our treatment plan, we focus on the respiratory status, the GI status. These patients do better if they're followed in CF centers because we have the latest and the greatest. We've also got other resources for these families. We encourage physical fitness, good nutrition, and that level of fitness is a correlate for their survival. So if I've got someone who wants to transfer to my center and they're a marathon runner, I am begging them, come on, you are doing well. Our goal in the treatment of the respiratory disease is to prevent or slow the progression of that disease. So we use bronchodilators, we use airway clearance, we use breathe-in treatments to decrease the thickness of the sputum. It's called alpha Dornase. We also do lots of antibiotics, both inhaled antibiotics, oral antibiotics, as well as IV antibiotics. A little caveat from our ID folks, remember that ceftriaxone does not cover Pseudomonas. And then as far as the gastrointestinal, we supplement the pancreatic enzymes that the pancreas no longer makes. So before they eat anything, they are taking pancreatic enzymes. We often use PPIs or H2 blockers to decrease the amount of acid. Number one, because if you remember, I told you a lot of these patients have reflux, but number two, it helps our enzymes to function better. And then we supplement the fat-soluble vitamins. Some of our patients require more nutrition than they can eat, so those patients are getting gastrostomy feedings to increase the amount of calories. All right, I'll move on. Alpha-1 antitrypsin. Let me just say, I get a lot of referrals for this. They're going to the wrong place because we rarely see respiratory symptoms with alpha-1 antitrypsin in children. If a child is going to develop signs and symptoms from alpha-1 antitrypsin, it's almost always going to be liver. Liver fibrosis, cirrhosis can develop in about 15% of the population, and this is what we see in kids. We rarely see pulmonary symptoms until around the 5th decade of life. The alleles responsible for alpha-1 antitrypsin occur on the PI locus. Normal would be PI-MM. Severely depressed or alpha-1 antitrypsin deficient would be PI-ZZ. And you see the normal values in what we would see with someone who's deficient. Heterozygotes, PI-MZ, would have levels above what is considered deficient and should have no respiratory symptoms unless they choose to smoke. And what we're going to see in the older patients would be early onset COPD, emphysema, and it's typically in the bases as opposed to in the apices as we would see in a typical COPD population. All right, so we're going to move into interstitial lung disease, a really, really rare one in children, sarcoidosis. This can be multisystem, but I'm going to stick to strictly the pulmonary. Chest x-ray can be variable. We may have hilar adenopathy. We could have interstitial alveolar infiltrates, or we might have both. A lot of people always draw an ACE level or angiotensin converting enzyme level. It's very nonspecific. If it's elevated, it's helpful. If it's normal, it didn't tell you anything. We can do bronchoalveolar lavage and look at helper suppressor ratio of the lymphocytes, and that might be helpful. But really, the best method and the easiest method is to do a transbronchial biopsy. And pretty much anywhere you go, you'll get what you need, which is non-caseating granulomas. We do culture and make sure that we're not talking about an infectious etiology. And if those cultures are negative, of course, this is what we have. Remember, erythema nodosum is a good prognosis. So if they've got the diagnosis plus E nodosum, that's great. If they're really bad, we treat with steroids. Most of these patients do great. And I always go with the rule of threes. About a third get better, about a third stay the same, and about a third get worse. And this is a nice example of hilar adenopathy that we can see here. And on CAT scan as well. Okay. So, I wonder if anybody's even heard of this. Alveolar proteinosis, extremely rare disorder. At LSU Shreveport, not so much, but only because we have someone who works with it. But it is rare, and what's happening is the macrophages within the alveoli are defective, and so we get a buildup of pulmonary surfactant. So therefore, we get this big right-to-left shunt with hypoxia. We diagnose by open lung biopsy, and the treatment is whole lung lavage under general anesthesia. Sounds crazy, but you ventilate, say, the left lung, and you wash out the right lung, and the next day you come in and you do just the opposite. This is an example of a patient with alveolar proteinosis, and just like we've talked about on other x-rays, again, you can see almost the punctate alveolar infiltrate that you could almost pick out of there. And on pathology slide, what you're seeing is this nice buildup of surfactant, this nice pink stuff that's all built up in there. Pink and blue. I would have made a great pathologist. And then as you wash it out, this is what you'll see. So you start off with almost like burnt potato soup, and you move down, and as you continue to wash it out, you ultimately wind up with a clear effluent that you're pulling out of there. So you're washing out all of that surfactant. Okay. Interstitial lung diseases that are associated with collagen vascular. I'm only going to talk about these. Lupus. We can see anything with lupus. You already know this. So we can have pleural disease, we can have pulmonary disease, we can have diaphragmatic disease, we can have hemoptysis. Lupus affects both lung and pleura more commonly than any other collagen vascular disease. That's the point you need to know. Scleroderma affects lung alone more commonly. It causes an interstitial fibrosis, and what are you going to pair up with scleroderma? You're going to pair up pulmonary hypertension. It's an intimal proliferation that causes pulmonary hypertension. That's the two you put together. And then the only other one I'm going to mention would be Sjogren's. That's associated with LIP. The only other thing I can think of that's associated with LIP is HIV. So if they tell you LIP, then it's one of those two, always. Okay. I'm sorry? Lymphocytic interstitial pneumonitis. So sorry. Okay. So we're going to jump into hemoptysis. We mentioned it briefly with lupus. The most common reasons that we're going to see a kid coughing up blood are these: infection, foreign body, or bronchiectasis. There can be some rare causes such as vasculitides, congenital heart disease, AVMs we talked about earlier, PE. Those are the zebras that you look for. So your initial evaluation of hemoptysis, first of all, you want to localize the source. Kid comes in coughing up blood, where'd it come from? So if it's coffee ground appearance, then it's the belly. If it's bright red or rust colored or it's mixed with sputum, it's probably coming out of the lungs. If we're talking about infection, then we're going to see fever, chills, classic scenario to fit. Remember, if it's the adolescent, you need to keep illicit drug use in mind. If we're talking about vasculitis, such as the pulmonary renal syndromes, then we're going to have hematuria associated with it. If we're talking about AVMs, we're going to be looking for telangiectasias. These are things you should sort of just scan and look for to sort of help point you in that diagnosis. Remember that about a third of the chest x-rays that you're going to see, a kid came in coughing up blood, are going to be normal. CT, if you're unsure or unclear about what's going on. You can always recruit your pulmonologist to do a bronchoscopy with lavage. We start to see hemosiderin within the macrophages 3 days after that coughing up blood episode or hemoptysis hemorrhage episode. If it's positive, you need to think about congenital heart disease as well. You need to do an echo and also consider lung biopsy. So you've looked for all the stuff and you come up negative. That's what you must say to make the diagnosis of idiopathic pulmonary hemosiderosis. This will cause intermittent and diffuse pulmonary hemorrhage, but you must exclude every other thing. This is a diagnosis of exclusion. All right, and then I'm going to talk just very briefly about the pulmonary renal syndromes, and we're going to be done. Goodpasture syndrome, it's an autoimmune disorder. We see males affected more commonly than females. If you're looking at an x-ray, it's going to look just like IPH or any other reason for pulmonary hemorrhage, but it also affects the kidneys. And what we see is a linear deposition of IgG and C3 along both alveolar and glomerular basement membranes. How do you distinguish Goodpastures from Wegener's? There are no upper airway signs with Goodpastures. You treat with immunosuppressives, plasmapheresis. This is a nice example of what a diffuse pulmonary hemorrhage would look like on chest x-ray. Nice, fuzzy. And then Wegener's is a necrotizing granulomatosis vasculitis. Remember, it does affect the upper airways, the sinuses, as well as the pulmonary vasculature with cavitary nodules and causes a necrotizing glomerulonephritis. You diagnose this one with ANCA. If it's positive, it's always C-ANCA. That's helpful, but you still need your biopsy to confirm it. And you can do a nasal biopsy, you can do an open lung biopsy. Your treatment is going to be with cyclophosphamide, with or without steroids. And this is a nice example of that cavitary lesion that we're going to see. You also see a nice nodular lesion right here. If I can get it there. All right. And that's it.